محمد هنحط الافلام ولا؟
اه يا دكتور، ثواني بتجهز بيحمل بس
خلاص
حاجات.
خلاص اوكي تمام. ومين هيبقى الكومنتر النهارده، السبوكس بيرسون النهارده؟ حد هيبقى متطوع ولا مفيش؟ هنكمل الفاسكر ان شاء الله.
Hello, good morning, doctor.
Hi Pradeep, how are you? You're okay?
Yes, doctor, I'm really fine. Okay, I think I will be the spokesperson, kida.
You will be the one in charge today?
Okay, doctor.
Okay. So,
How's everything, doctor?
Pradeep, do you just want to remind us how to differentiate between different types of angios, of arteriographies?
Yes, we have the outline conventional digital subtraction, CT angiography, MRA, and in order to differentiate that, we first see the catheter. If we see catheter, then it goes to the conventional, line. And if we don't see that, then it goes to CT angiography or MRA. And in case we see catheter, we have two options. If we see bone or calcifications, then it is conventional. If we don't see bones and calcifications, something like that, then it's digital subtraction. And on the other hand, uh, in CTA we can see bone clearly. In CTA shows that, but in MRA that is not seen, and CTA can also be subtracted. This is the outline.
Okay. What do you see on a plain film? How about a plain film? What would you see if you're reviewing a plain film of a blood vessel? What would you see? What you look for on a plain film?
We will see either calcification, or especially if contrast is used, then we can see branching. If it's arteries,
a plain film, we're talking about a plain film. We're not talking about a contrast image. We're talking about plain film. How about a plain film?
Okay, for plain film, so you can see the opaque structure like bone, calcifications, stone, these.
Yes, we're concentrating on the vascular, but yeah, stone. But let's talk about the vascular, point of view. Calcification, wall. What else?
And also the thrombus.
Thrombus. We see the thrombus on a plain film. You can see the thrombus on a plain film.
No.
A plain film. We're talking about a plain film. So what else can we see on the plain film other than calcium?
Catheter.
You can see the catheter. Okay. Or what else? What else can you see inside an artery, for example?
Inside artery. Inside, I think calcification naturally. If we can see the calcifications.
We mentioned that, but what else can you see inside an artery?
Yes, IV filter, masalan, stent, IV filter.
A stent, yeah, and a stent. Yeah,
yes.
Any previous intervention, yeah. That
yes.
is it. And what else can you see in the soft tissues? What else can you see in the soft tissues?
Soft tissue, we can see calcification, Bordo.
Related to vascular. You can see, this is the broad things that you can see. You can see calcium, yes. But what can you see in the soft tissues in some of the vascular disease or the vascular problem? We've seen it before. We've actually seen before. What is it that you can see?
In soft tissue. In soft tissue.
What do plain films show in general, other than calcification and soft tissues? What else do they show? Something important that they show.
Interventions and bones. These are things. Interventions, maybe.
We mentioned it, but how about air? You did not mention anything about air.
Oh, yes. Yes, yes, yes.
They usually say that plain films will show the white bits, the black bits, and the gray bits. The white bits are the calcium, whether it's in the skeleton, outside the skeleton, and the black bits, which is the air, and the gray bits, the soft tissues. Sometimes they call it the white bits and the black bits and the gray bits. So it may show air. It may show air in subinstitutions. What does this imply? What about if air is present?
Subcutaneous or or gas gangrene, subcutaneous infection or gas gangrene.
Gas infection, a gas infection, not particularly gas gangrene. It could be any gas-forming infection, so it's not particularly gas gangrene. So it's more broad than that. It's broader than that. It's a gas-forming infection. That's it. Okay. We'll wait until the images are sort of.
دكتور احنا هنبدأ منين؟
أفندم؟
هنبدأ منين؟
هنبدأ إيه؟
هنبدأ منين؟ Which image؟
يلا لا we can start with this one with the foot. Or we can start with this one. خلاص, let's start with this one that we reviewed, I think, earlier. Let's start with it. Yalla, Pradeep, what's going on here?
It's a CT angiogram of arc of aorta and its branches.
On which part of the aorta?
It's an arc of aorta.
Arch of the aorta. So it's an arch aortography, a CT arch aortography. Yes, and what are the branches that you can see?
On the right side is innominate, common innominate.
Pradeep, can you press the annotate button on the upper right so you can use the mouse in case you want to point to anything?
Okay, come on. Can you see? Hello?
Yes, but
yes, Pradeep, go on.
This one is the right brachiocephalic.
The right brachiocephalic is the right and the left.
And this is the
right and the left.
And this is the left common carotid. This is left.
Hold on for a minute. Are you saying right brachiocephalic, or are you saying what are you saying about the brachiocephalic?
Brachiocephalic.
Yeah, which side is it? The right or the left, or is it neither right or left?
It just, it's right. There is no left.
So it's not the right. It's the brachiocephalic.
Yes, it's brachiocephalic.
It's the brachiocephalic. You don't call it the right because there isn't a left, as you've just said. What are the two branches that arise from the brachiocephalic?
This one is common carotid, and this one is right subclavian, which is going this way. This is the right subclavian.
Okay, subclavian and common carotid of the right side. Point to the internal and the external carotids. Okay. Go a bit more distal and point to the internal and the external carotids.
This one is internal, and this one is external.
How do you know? How do you know?
First, it's a branching. External have a branching, and internal.
That's the answer. That's the answer. That's the answer. It's not anything else. That's the answer. Whichever artery is branched, it's the external. Whichever artery is not branched, it is the internal. Obviously, one contains inside the head, but I mean, you may not have the luxury of following it inside the head. So that's it. Where do you expect the chemoreceptor area to be? Where's the chemoreceptor? Where are the chemoreceptors? Where do you expect the chemoreceptors?
Chemoreceptors, it's this area. This is the aortic bifurcation and carotid bifurcations.
Yeah, go on, point to it. Carotid bifurcation. Where is the carotid bifurcation?
This point, this.
The
Can I,
carotid body. Where do you expect the carotid body to lie? Yeah, go on. I can't see anything.
just a second. Actually, I draw. No, I have to choose.
خلاص, okay.
Can you see, doctor, my mouse? Can you see my mouse?
I can't see anything at the moment. I can't see anything at the moment. خلاص, forget about it. How about the left common carotid? Where's the left common carotid? You pointed to it before, but go on. Where's the left common carotid?
This is the left common carotid.
I can no longer see anything. I can no longer see anything. I can no longer see your
Okay.
mouse at all. I don't know what's happening, but can anyone see whatever
لا يا
Pradeep is
دكتور.
pointing to?
No, we cannot see your mouth, Latif.
لا يا فندم.
Now.
Can you change the type of the one you are using?
Yes, I changed that. I thought okay, I will cut it and again I will select it.
There is
Again I
something like that. Can you use the spotlight?
spotlight. In view options, I see request remote control, then annotate and exit full screen. These three
Yes,
options I see.
annotate, yeah.
And annotate, once I click, I mean, I am trying to move, but there is nothing is happening. Can I rejoin so that I think maybe it works? Hello.
Yes.
Yeah, go on. Go on.
Okay.
طيب حازم جرب كده، ممكن تجرب يعني تعمل انت الانوتيشن.
ليه مش هو المفروض يقدر يعملها ببساطة؟ مش بيبقى فيه كده اوبشنز كتيرة تحت المفروض
بالظبط
يعني Pradeep, why don't you give it another try, because I'm sure you can use
Yes,
low
now I think
methods.
طب كده شايفه يا صغير؟
now I think
تمام. And now we can see Pradeep's drawing. Okay, Pradeep, we can see you now. Okay.
Pradeep, go on. Where's the left common carotid?
This one. What's happening with my computer? I really don't know. Again, it's not showing.
How about the left subclavian? Can you see the left subclavian? Okay, we can see it now. How about the left subclavian?
This one.
Okay, show me the vertebral. I'll show you the vertebral.
Okay, vertebral. This on the lower images. In the lower images, there is a vertebral.
Yeah, go on.
This doctor, just a second, okay. Hello.
Yeah, Pradeep, go on. Where's the vertebral?
This one is a vertebral.
Okay, this is vertebral, and it joins to form which artery? The two vertebrals join to it to form which artery?
Basilar artery.
The basal. Can you point to it? Can you point to it?
This one. These are the basilar artery.
Okay. خلاص يبقى this shows the circulation to the brain. Sometimes it's called four vessel angiography. The brain obviously is supplied by four vessels. They're the two common carotids and the two vertebrals. At times you call that a four vessel angiography. The two carotids and the two vertebrals. Okay. It's just normal. There's nothing abnormal about it. It's obviously a CT. Let's get on with the next. Let's get on with the next image. Yalla, Pradeep, how about this one?
Um, this is this is this is CTA Bordeaux.
It's, do you really think that these images look like the ones that you've just seen before? Or is this looking like a CT angiography?
Actually, I can see the popliteal artery here. It's because
But what,
if you
what type of angiography is it in the first place?
it's CTA, I mean we cannot see the catheter or anything
But
else.
because the catheter will not be present in this area, the catheter will be present at higher level. So catheters may not be seen because you're not reviewing the site where you punctured. Where do you usually puncture? What is the usual puncture site?
A femoral artery
Femoral. So
inguinal
you
region.
cannot see the femoral here. This is a conventional angiogram. It's not a digital, it's not an MRI, it's not a CTA. This is the conventional angiogram. Yalla, what are the branches that you can see?
Here I can see the up here above P1, then this one is the P2, and this P3, and this popliteal artery, and then we have this one, the medial is the posterior tibial artery.
Okay.
This one is anterior tibial artery, and this one is peroneal.
How about the stem which gives rise to the peroneal and the posterior? How do you call it? There's one artery that you've not pointed to
Yes,
between the antitibial and the bifurcation.
This one is peroneal. I mean, I forgot doctor's name. So
It's
common.
just the tibioperoneal. That's just the tibioperoneal. It's the tibioperoneal. It's it hasn't got. It's just the combination of the two of its two branches. The tibioperoneal. Obviously, how about the right side? What's going on with the right side? This is on the left side. How about the right side?
Right side, we cannot see blood. I mean arteries.
You cannot see any arteries. So obviously, there's a more proximal lesion that we need to review. So this image would just show the anatomy of the popliteal, as we call it, the trifurcation or the bifurcation, whatever you want. So I hope that the branches of the popliteal artery are quite clear. Yalla, let's get going. Let's just get going. Yalla, we'll go on. Yeah, go on. What's this, ya Pradeep?
Hello.
Yeah, Pradeep, go on. I can hear you. Yeah, go on.
Just a second, doctor. I want to erase this. I mean, it's disturbing.
Sorry?
I want to erase this drawing.
Go on, erase them, yeah, please. Go on, erase them.
Here in this image, this is X-ray. This is the X-ray of the foot, lateral view.
Okay. Name the bones. Go on, name the bones.
Okay. This is the talus, calcaneus.
I can see nothing. I can see nothing at the moment. I cannot see any sort of.
This one is a talus.
Can you choose another color for the annotation?
Okay. Red. This one is talus.
Which one is this one? The talus. This is the talus. Yeah. Calcaneus.
This one is a navicular.
This is the navicular. It looks like a boat. What is the carpal navicular? What is the carpal navicular?
Scaphoid.
The scaphoid. So the navicular, it's the navicular that you palpate the dorsalis feeders against.
Yes.
It looks like a boat. Yeah, go on. How about the ones in front of the navicular?
It's a navicular. I think cuneiform. It's in wrist. I think it's Doctor. I forget his name.
Which one are you talking about? Point to something and then what?
This
Which?
this row.
These are the cuneiforms, the three cuneiforms, the
Oh,
cuneiforms,
cuneiforms.
the
Okay.
three cuneiforms. How about the one that remains towards the little little toe? There
This
is
one
one
is
that, yeah. How about this one?
cuneiform. Then
It looks like what? What does it look like when you've already drawn its outline? It looks like what sort
was
of, is it a rectangle? Is it a cube? Is it a square? Whatever it is.
bit rectangle type. I think.
Okay, it's called the cuboid.
Oh,
It's called the cuboid. Okay,
cuboid. Okay.
so let's review the anatomy once more. It's just to review the anatomy to be able to name the tarsal bones. Go on again.
This is talus. This is
The
calcaneus.
talus, the
This is
T. They say T for T. The talus for the tibia. It's the talus that articulates to the tibia. Okay, the calcaneus. Where's the calcaneus?
this one is calcaneus.
This is calcaneus, the heel bone. Yeah.
And
About the one that articulates with the talus.
uh, this one in front it's navicular. It's articulate with the talus.
The navicular. Yeah. The navicular. It looks like a
Then
boat. It's very clear. About
and then cuneiform, and then cuboid. This one is cuboid.
this is the cuboid. How about the cuneiforms? Where are the cuneiforms?
These are the
How
cuneiforms.
many how many tarsal bones have you got?
Tarsal total 1, 2, 3, 3, 6, 7.
Seven tarsal bones. Okay, there are
Yes,
three
7.
cuneiforms and the cuboid and the navicular and the talus and the calcaneus. Can you see anything abnormal about this image?
Um, here, I think tibia and talus joint seems a bit close. I mean, they're more
The bones are normal. The bones and the joints are normal. You can see something, a foreign body underneath the
yes,
the,
yes,
the metatarsal of the little toe. You can see
yes.
it. Point to it. Point to it, please.
This
Oh,
one,
there it is. Okay.
yes.
Uh, this is the one, and it's a foreign body. And at times you're asked to remove a foreign body, and you should obviously get by planar images. Otherwise, you never know where it lies.
Okay.
Yalla, go on. The next, please.
Okay, this one. Hello.
Pradeep, go on. Go on.
Okay, this one is the CT angiography.
So you think it's a CT angiography? Okay.
Okay, yes, CT angiography. Because I cannot see the catheter or anything. Maybe it's a subtracted CT angiography.
Okay. So you think it's a CT angiography? I think you're correct. Yeah, go on. The arteries are
Yeah.
heavily calcified, so I think it's a CT angiography.
Yes,
Yes. Go on.
and it shows this extensive. There is collaterals in lower limb, thigh.
But I mean, start with the anatomy that you know, and then follow the collaterals. But I mean,
Okay,
there is a lot of collaterals. But go on. Where is the aorta? Start with the aorta.
okay. This 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 the oh, okay. This one is aorta. This
is progressing into the external iliacs. Review the other image as well. Review the other image as well.
I think in other image, I think it's blocked. I think it's blocked.
Yeah, which artery is blocked? Which artery is not patent?
Common. Sorry, I mean aortic bifurcation. At that point, it has been blocked, and common iliac also.
Yeah, which common iliac is blocked?
It's on the. I think both. I think.
You rethink both sides? Well, I think the right side is okay. The right side you've got there, but then the left side there, it's all collateralized.
Oh, there are a lot of
Okay.
vessels. I mean, it's really hard to.
Yeah, it's not an easy image. It's not an easy, but I mean, this is how we get the images at times. Okay, yalla, go on, continue on the right side. What's happening on the right side?
On the right, we have this one.
Show me the common iliac on the right side. Show me the common iliac on the right side.
Okay, this part is the common iliac.
Well, at this time, I mean, in this stage, it's probably the external iliac because we're getting closer to the thigh. Okay, so this is common iliac and external iliac. Then you've got a load of rubbish in the thigh.
This one is common.
This one is common, probably. Yes, you're right. The other side is blocked. You've got a lot of collaterals. Show me the collaterals that you took.
Collateral of the thigh, doctor.
In the pelvis, collaterals in the pelvis. There are loads of collaterals in the pelvis.
Yes, a lot. Actually, these are the collaterals.
On the left side, I'm talking about the left side in the pelvis. Yeah, these are the ones. Do you want to erase all these marks, please, Pradeep? Go on erasing them. Yeah, show me the common femoral on the left side. Show me the common femoral on the left side.
Okay. This one.
Yeah, this is the one, and then it's occluded. Then show me the popliteal. Show me the popliteal.
Okay. It's this one.
So the SFA is this is the popliteal. There's a block between the common femoral and the popliteal. The SFA is occluded, and then you can see something in they're bad images, but at times you have to test yourself for the bad image because not all images are perfect ones. The ones that we usually select to demonstrate are the ideal ones, but at times they're not. It is as bad as this one. How about the other side? Can you see anything in the thigh?
No, it's totally blocked. It's
they're all collaterals. Can you see something? Can you locate something in the leg? How about in the leg? Can you identify an artery that you know in the leg?
Yes, it's a posterior tibial artery.
Pain Hoa, show me the posterior tibial. Yeah, you're right. Yeah, this is posterior tibial. So yalla, let's just summarize or wrap up. This is a CTA that shows. Yalla, what about the right side? What does it show on the right side?
On right side, it's patent. On left side, it's blocked.
Yeah, but patent, which arteries are patent and which arteries are blocked? Because I mean, we want to review the artery from the aortic bifurcation all the way down to the leg.
Okay, on the right.
The right, yeah.
It's a common iliac, in external iliac, and femoral is patent, but after femoral till popliteal, it's totally blocked. I mean, superior femoral artery is blocked on the right side.
How about where does the flow restore? Where is the flow restored?
Flow is restored through the deep profundal artery. I mean, and collaterals.
Yeah, but where is it restored? Where is it restored? Which is the artery that you can see next to the occlusion? Where is the artery that you see next to the occlusion?
It's posterior tibial artery.
Tibial. How do you call this reconstitution of the flow? How do you call it when an artery is blocked and you can see an artery distal to it? How do you call it?
Distal runoff.
The distal runoff. So it's all included in distal runoff is it's the positibial artery, which is bad enough. How about the left side?
On
How
the
about
left
the left side?
on the left side, we have blockage of the common at the bifurcation. I mean, left common iliac, and then we have patent left femoral, and then we
Which
can see.
femoral? You cannot talk about the femoral. You have to
It's
talk about the profunda. You have to talk about the common, the superficial. But you cannot just say femoral. You can just say femoral. So which femoral is patent?
it's profunda is patent.
The profunda is almost always patent. If the profunda is occluded, what is your deduction? If the profunda itself is occluded, what is your deduction? What do you deduce? It's
Most
almost
probably,
almost always diabetic. If you get profunda occlusion, it's almost always diabetic. So you don't ever get profunda occlusion. The profunda itself is almost never occluded. But then which artery is occluded? It's the common femoral and the profunda. Which artery is occluded?
it's a super ASFA
The SFA, and then it reconstitutes the runoff
reconstitute
in this case
popliteal. Here it's popliteal
popliteal.
artery.
Okay, خلاص. This is a CTA. The arteries are calcified, and there are loads of collaterals like Pradipa was telling us. There is a left common iliac block with a runoff on the common femoral, and then there is an SFA block with a runoff on the upper popliteal. On the other side, there's a inclusion of the superficial femoral all the way down to the reconstituted positibial. Multi-level disease. Okay,
Mm.
yalla, let's go on.
Doctor, this patient do have this, I mean, aortic aneurysm. There seems, I mean, dilatation. This one, this area is normal.
I'm not so sure. I cannot tell. I cannot tell. I mean, maybe it's suspicious, but
Oh,
I have to get a proper image of that. I have to get an axial cut. Axial
oh,
cuts are the best. I have to bear this in mind, but I'm not so sure. I don't think it is. مش
okay.
عارف. Let's review the other image. I think there are areas of stenosis within the aorta.
Mm. Okay.
Yalla Pradeep, what's going on here? Now we had the plain film. Mohammed, we had a plain film. Okay, yalla Pradeep, what's going on here?
Okay. This is the plain film of the neck and upper chest. It shows
You don't call it the neck of the upper chest. In order to view the neck, you need to image the upper chest. So you cannot say the upper chest. You can't say that because it doesn't mean anything. It
oh,
means that you're actually imaging the neck and not the chest. You cannot
mhm,
image part of the chest. If you want to image the chest, you have to image the whole chest. But this is simply image neck X-ray.
tamam.
Okay. Yellow. What does it show?
Here we can clearly see the left side. This stent in I think it's left subclavian. This stent in
It's a
left.
left subclavian. Yeah, a stent in the left subclavian.
Mm.
Okay. Yes, this is correct. Can you tell me why? Why was this stent put? Is this man got or this woman
Most
got?
probably he has, I mean, or she has blocked Muhammad. His name is Muhammad, so it's main. If
مالناش
he,
دعوة you should be mentioning his name. Why did you mention his name? Why did you mention his name suddenly? يعني you should be cautious mentioning people's names. They can go on. What about the skeleton? Can you see anything abnormal with the skeleton?
mm, the skeleton, I think skeletal. It's
Point towards the first rib. Show me the first rib. Go on, show me the first rib.
okay. Yes, there is. This one is the one. This one.
You really think it's the first rib? Which one did you point to? The one with the blue or the one with the red?
I did with the red. Oh, it's a extracervical rib. It's on right and not on the left.
Yeah, so the cervical rib on the right side. Go on. Show me the cervical rib. Show me the cervical rib.
This is
This is the one. Why did you identify this as cervical, not in the thoracic? Why do you
yes.
think this is cervical?
First of all, the transverse process, I mean, it lies upward, I mean, upward incline. And also we can follow the course of that rib. But in case of rib, the transverse process, that is totally horizontal.
Let's point to what you can see. I mean, let's not theorize. Just let point to what we can see. What is it that you can see? Yalla, go on. You identify this as a rib, as a cervical one. Why? Why was this a cervical rib? Why is it a cervical rib?
First, here we can see this, I mean, this transverse process, it is faced upward.
Upward. How about its the transverse sources with which this articulates?
And its other end is totally free. I mean, this end.
You don't talk about its end. You talk about its medial side. You don't talk about how it ends. You don't talk about that. You're talking about its transverse process. How is its transverse process directed?
It's directed upward.
It's not directed upwards. If it's directed upwards, then it's a thoracic rib. Show me the first rib. Show me the first rib. Go on, show me the first rib.
Oh, sorry. I'm really sorry. This one is the first rib. And
Yeah, this is the
here
first rib. Follow its transverse process. Follow its transverse process.
this one, yes, this is the normal
Let's
one. I guess.
concentrate on the right side. Yeah, Pradeep, please. Follow its transverse process. Yes. Yeah, point towards its transverse process. يعني the transverse process itself, not its lower limit. Point. أيوة, خلينا على right side, please. So point towards the transverse process of the first rib.
Okay.
Go on. Okay, how about the transverse process of the cervical one?
It's
How about the transverse process of the cervical rib? You can see the difference in direction. One is directed upwards. One that is directed upwards is the thoracic, and one that is directed downwards is the cervical. So you can see how they sort of converge, how they converge. How about the other side? How about the other side? Can you see anything abnormal about the other side, or is it all normal? Apart from the stent, I mean, apart from the stent that you did correctly say it lies in the subclavian, in the left subclavian. What is this that you pointed to?
This one is a transverse process.
Where is the this is the transverse process, really? Do you really think this is the transverse process? Do you think so? The transverse process lies more medial. Compare it to the other side. Compare it to where is the transverse process?
This one is a transverse process.
Yeah, this is the transverse process. How about the transverse process that lies below it? What about its direction? The direction of the transverse process that lies below this one?
It's I mean the point the I pointed. I mean that is horizontal one, and below it's directed upward.
Yeah, you're pointing to an incomplete rib. Don't point to this point. Yeah, it's the transverse process. Yeah, there. Yeah, go on. Stop at the level of the transverse process, please. This is the one. Oh, this is the one. The thing that lies between the two is a rib, is an incomplete rib. The one that lies, that is this is an incomplete rib. Okay. But this is, what does the rib do to the RC? What does the rib potentially do to the RC?
It I mean, it narrows that opening so it can compress.
The opening? Does it narrow the opening? Does it narrow the opening?
No, it's not narrow, but it upshifts upward. I mean, that.
Yeah, but not the opening. It does not narrow the opening of the subclavian. It narrows the subclavian along its course. Okay, so it
Around
compresses the subclavian, and what does it do? Distal to the narrowing.
distal to the narrowing, there will be, I mean, less blood flow and may collapse.
May collapse, but in fact, what happens? It may collapse, but it may not. What happens sometimes when there's a stenosis, distal to the stenosis? What happens in particular in this situation? Zain is
Post-synaptic aneurysm.
post-stenotic dilatation, absolutely, and it may create an aneurysm. Okay, so this man or this woman, this individual, let's not mention the name. If you want to mention the name, you'd better mention initials. Has got bilateral cervical rib, a complete one or more developed one on the right side, less developed one on the left side. And he's got a stent in subclavian, whether it's related to a thoracic outlet or not. It could well be related to a thoracic outlet or not necessarily. Cervical ribs are in the vast majority asymptomatic. The ones that you see on a plain film are usually asymptomatic. Okay, let's just just can you tell me what do you review on a plain film, ya Pradeep? When you're reviewing a plain film, what do you review?
We see the white is, I mean, white opaque and air, blackish and gray areas. These three areas.
The white areas can be calcium. Where do you see the calcium?
In
Where
the
do you see
bone
the calcium? In the bone, or where
or
else do you see it?
in the walls, calcifications.
Yani outside the bone, outside, whether they're stones, whether they're calcifications. You comment on the skeleton, you comment on calcium, whether it lies in the skeleton, whether it lies in a stone, whether non-calcular. How about the air? What about your comment on the air?
Air, it can be inside the soft tissue. That means that infectious.
خلاص ما لناش بس just comment soft tissues. Yeah, where else? Where else can it lie?
And it can lie in, I mean, space areas like gallbladder. I mean,
In the lumen or viscous, it can lie in the whole in the lumen or viscous. It can lie in a lagoon other than the lumen or viscous. Where else can it lie?
outside the film. I mean to say the.
If you go from the lumen of the viscous, go to the outside. In the lumen of the viscous, and then go to the outside. Where else can it lie?
Airway, our airways.
La, la, go from the lumen of the hollow viscus. Where else can it lie? Go systematically. Where else can it lie? If you're going to the outside, where else can it lie?
In peritoneal areas.
Yeah, in a body cavity. Yes, but then it can lie inside the wall. It can lie intramural. It can lie inside the wall. So it's either in the lumen, in the wall, or in the body cavity, or interstitial. But these are and it may be normal, abnormal, because if you find air inside the colon, it's normal. If you find air inside the gallbladder, it's abnormal. So it's either in the lumen or viscous, or in the wall, or in the body cavity, or interstitially.
Okay.
And then there are the gray bits, the soft tissues, and so forth. But when you comment on a plain film, do not omit these parts. So this was a stent in the left subclavian, together with a bilateral cervical ribs, which were variable, or a complete one and incomplete one. Remember that how to identify cervical rib. Only how do you identify cervical rib, ya Pradeep? Go on.
We will see the transverse process.
You first locate the rib that is highest. You first locate the highest rib, because obviously the cervical rib will be the highest one. So you locate the most superior rib, and then what do you do?
And then I follow its course and see the transverse process.
Okay, and then?
And if it's horizontal, then it's cervical rib. If it's pointed upward, then it's thoracic rib.
Thoracic rib, absolutely. So this is the way you tend to diagnose the cervical rib. There's no other method. You don't count the ribs, you don't do anything. It's just that you identify the highest, the most superior rib, then you follow it immediately until you identify the direction of its transverse process. If it's upwards, it's a normal rib. If it's downwards or it's transverse, then it is a cervical rib, just like you're mentioning. Yalla, go on.
This image, this is CT angiography. So I think it's subtracted. CT angiography.
It's subtracted, but I don't think it's a CT. I think it's a digital subtraction angiogram. Okay, I don't know how about the catheter. I cannot identify catheter easily, but I don't know that there's a catheter coming from above. Okay, yalla, go on.
Uh, this here, this one is we see this one is the aorta, I mean.
Okay, this is the aorta.
Hmm.
Yes.
And
Why don't you comment on an image where there is more filling, more contrast?
okay, in the middle row.
Okay, go on.
Mm, this is the bifurcation of the aorta,
Okay,
and then we have a right common iliac and left common iliac, but it seems stenosed in the right common iliac.
it's stenosis in the right common iliac. Absolutely, there are multiple areas of stenosis. And how about the left common iliac?
Left left also seems a bit stenosis, and it shows a lot collaterals beside it.
Okay, there is also stenosis in the left common iliac, probably along its entire course. How would
No,
you treat this man? How would you treat this man or this woman?
I will go distal runoff is, I mean, femoral is okay, so I will choose aortobifemoral grafts. Aortofemoral.
Really? In the third millennium, would you go
Mm.
for an orthobifem in this situation?
No,
Localized
first
stenosis like this? What would you do?
I will balloon dilated and stint it
Yeah,
also.
absolutely. Absolutely. You would stent these iliacs.
Mm,
You would absolutely stent these iliacs. This would be an ideal. دي اللي بيقولوا عليها must. You must, if you do not stent these iliacs, then you shouldn't be operating the first place
mm,
because it would be very unfair to expose this man to an orthobifemoral. Okay, so ده اللي بيقولوا عليه must. In other lesions which are more difficult, you could or you should, but in this situation, you must angioplasty them. In fact, you stent them and then you dilate them. Yeah, go on. How about the image below the one that you're pointing to? What are these vessels that you can see?
okay.
The image
Uh,
just below to the one that you're pointing.
Mohammed, can you please zoom a lower row, please, so that I can. Yes, the lower row, lower. Yes. Thank you, Mohammed. No, no, no.
Yalla, Pradeep.
Okay, fine. I mean, bring
Okay,
in the.
Awalan, can you see that these are not CTs? Can you see that these are images that were simply subtracted? Can you see the orby bones there, the pelvic bones and so on? Okay, and then they were subtracted. Yalla قول لنا كده what are the arteries that you can see on the zoomed images?
Okay, this was the upper. I mean, part of this part of the common femoral.
Which part is the common femoral?
It's I mean, common femoral where its branches. I mean, after that, it's distally it's branch into superficial and profunda.
Yeah, where is the superficial? Where is the
S-
superficial?
this one is superficial, and it seems later it's blocked.
La la,
Uh,
this is not the superficial. This is not the superficial. And it's not
no,
blocked. The superficial is just more medial. Yalla go on, where is the superficial?
oops. Yes, it's medial. Sorry, superficial is medial. This long is a superficial.
بالظبط. And the other bunch is the profunda. The other group of vessels, this is the profunda with its branches. How about the other side?
Mhm.
How about the other side? How about the right side?
Hello.
Yeah, Pradeep, go on, go on.
Actually, doctor, I didn't hear. My internet connection was weak. What you said? I mean, I didn't hear the question.
How about the right side? How about the right side?
Okay.
How
On
about
the
the right side? Go on. What's happening with the right side?
Mohammed, can you bring image in the middle, please? I mean, on my screen, I cannot point it with my. Okay. Sukran Mohammed. Uh, in the right side, this one, I mean, this long one is our superficial femoral artery.
Then it's where is the superficial femoral, for God's sake? Does it look like the other side? Does this look like the other side? It doesn't. It starts, but it does not continue. It does not fill as much as the one on the left side. The one that you can see there is the profunda again. Yalla, point towards the profunda. Point towards the profunda. Pradeep, are you there? This is the profunda. Well, the SFA, you continue all the way down to the profunda. If you follow the next image, it may be clearer. Move to the one to your right hand side, yeah, Pradeep. Move to the image to your right hand side.
Okay.
Oh yeah, where's the profunda? Continue the profunda. Yeah, continue the profunda.
This one, I mean the lateral one.
Oh, okay. How about the superficial femoral? Where's the superficial femoral?
And this this medial one is superficial femoral.
It does not continue. It does not specify as well as the other side. Okay,
Yes.
so yalla, go on. What is the diagnosis? Just wrap up. Well,
So it's a conventional angiogram
it's not a
showing.
conventional one, it's a digital one. It's a
Sorry,
digital one, it's not a conventional one.
abstraction.
It's a digital. We've got a bit of problem with this clear because we haven't got a catheter. It's in fact a digital subtraction angiogram, yes. And what does it show?
It shows the block on the right side. It shows the blockage of the so ESFA.
No, but it showed something in the iliacs in the first place.
Yes, in
It showed
iliac.
something in the iliacs. You've been talking about the iliacs, and this is the same image. It's a continuation. But what
Yes,
did it show in the iliacs?
it's stenosed, uh, bilateral stenosed.
بالظبط, but it's stenosed, and it also shows SFA on the right side that is not properly opacifying. It needs more images. And what did we choose as a form of treatment, if indicated?
We use stent and balloon dilatation angiography.
Okay. Okay, let's proceed with the next image.
Okay, this one.
Like, there was another image. كان في image كده, a plain film of the abdomen. كانت جات يا محمد كده. These طبعا stents of the, I don't know, the brachial or the axillary يعني. Forget about them, it's not important. ايوه دي بالظبط.
Okay, this one is a plain X-ray. This one is a plain X-ray.
Yeah, this is a plain X-ray of the abdomen, yes.
And here we can clearly see stent bilateral in common iliac.
I'm not so sure whether it's clear or not, but it's there. Yeah, point to the stents.
Just a second. This one and this one.
This one and that. Yeah. So these are the stents in the iliac and the aortic bifurcation, the so-called kissing stents, as we call them.
Yes.
They're kissing stents, as we call them. Yeah. So this is how we have managed the man that we have just seen, the woman that we have just seen, the one that we're reviewing their images in a minute. Can you
Oh,
see the barbs? Can you see the barbs of the
yes,
stent?
yes.
Where are the barbs?
These, I mean, here we can see the points. I mean, that
These are the
white.
barbs, the radio opaque points at the end of the stent. How about the
Yeah,
struts? Where are the struts?
this,
Where are the struts?
and this, these are the in between. These are the stress.
So the struts, the metalwork of the stents. Stents are commonly formed of. What are stents commonly formed of?
Stint. It's I mean, it may be metallic or it may be we can TF PTFE.
They're usually metallic. It's nitinol. It's nitinol.
Night.
The metal that we use is nitinol. Nitinol is an alloy of titanium and nickel. Nitinol, nickel and titanium. Nitinol. We call it nitinol. It's got a memory. It's got a thermal memory. Uh, can you see the Can you see the source shadows? Can you see the source shadows? Point to the source shadows.
Yes. Okay. This on the both side. These are the source shadows.
Lateral boundary of the source. You have to point to the lateral boundary, otherwise there won't be a shadow. So where's the lateral boundary of the source?
Okay. This on the left side and this
Okay.
on the
How
right.
about all this? How about all these shadows that are filling the abdomen? There are speckled shadows of gray and black everywhere.
Here in the colon intestine.
So this is the colonic. These are colonic shadows full of fecal matter. These speckled appearances of gray and black, they are all fecal matter inside the colon. Okay, so this is, yalla, give a wrap up. What's this?
Okay, this is a plain film showing kissing stint in
Is this a
bifurcation
proper
chromosome.
abdominal film? Is this a good abdominal film?
I think yes, we can say it's abdominal film.
Yeah, is it a good abdominal film? If you say it's abdominal film, is it a good one?
No, it's not that good. It's not good one.
Why isn't it good? Why do you think it's not good?
Because the I mean colonic shadow plus it's not that clear. I mean a lot of zigzag.
Yeah, but okay, but the thing is that you haven't shown the cupolas of the diaphragm. You have not shown the upper limit of the abdomen. In order
Oh,
to view the abdomen properly, you have to show the cupolas. Otherwise, you may encounter air, lead the cupola, and you will not see it. But in order to get a proper plain abdominal film, you have to see more of the lower chest, which you have not. But this
okay.
plain film shows bilateral iliac stenting, just like the one we were talking about a few minutes ago. The barbs are the sharp ends at the are the sharp bits that lie at the end of the stent. The struts are the metallic work of the stent. We also talk about the nitinol has got a thermal memory. It's got a memory. Um, it's got a memory that tends to get it to its original shape, and a thermal memory. It contracts in cold temperature and it expands in higher temperatures. Nitinol is an alloy of nickel and titanium. Gonna go on. Let's proceed.
This one shows a stent in
خلاص.
right.
Stents in the axillary brachial segment with the barbs and the I don't know, the struts, and its stenosis in the middle. خلاص,
Mm.
just forget about this one. It's not. Yalla, go on. What's this?
This is a digital subtraction. Digital subtraction in geography.
Can you see a
Mm.
catheter?
Catheter. I cannot see catheter, but I mean this type of images in book.
لا لا,
They have.
شوف الcatheter. The catheter is clear. You can see a
Okay.
catheter clearly. You can see a catheter and it's clear.
Okay, I'm trying to see. Yes, yes, I can see that. Yes, it's from above in the aorta.
Yeah, where point to it, point to the catheter. You should all be able to identify catheter in the direction in the direction of its whatever. Yalla, where is the catheter? Are you going to point to it?
Yes, I am pointing. This is it. This.
This is the catheter
Yeah,
there. And where did it get inside the aorta from? How did it reach the aorta?
From subclavian.
Do you really think
Or
it's a good idea to is it easy to identify the subclavian and puncture it? You may do that, but do you think it's really easy? Subclavian, which is easier than the subclavian? Which is easier than the subclavian?
I mean, femoral area. I mean, from the femoral is easy.
This is not the femoral. You've been talking about that it's coming from above.
Yes,
It
it's
couldn't have
above.
come from the femoral. Yeah, but what other artery than the subclavian would you puncture in order to reach the aorta?
Internal. Sorry, I mean axillary.
Yeah, axillary.
Axillary.
Transaxillary or transbrachial.
Yes.
The brachial and axillary are much easier than subclavian. Subclavian is stuck between the clavicle and the rib, and it's not easy to puncture. You can puncture it, obviously, but it won't be the ideal. The ideal would be to go through the axillary or go through the brachial. Sometimes even the radial. Cardiologists may go even through the radial, but then you need a micropuncture set. You need a puncture set uh, that is appropriate or adequate for the very tiny radial. Which technique do you use in order to puncture an artery? Which technique would you use in order to puncture an artery?
Seldinger technique.
The Seldinger. And who was Seldinger?
Seldinger, he was actually he was a student when he discovered this. And
I don't think so. I don't think that he was a student. I'm not so sure. We have to review that. But who was he? Which nationality and what specialty was he?
nationality, I think he. No, can you hear me? I cannot hear you.
Yalla, Pradeep, are we? Yalla, go on.
Okay. I mean, let's which image? This one?
I don't know. We have to fix on whichever we want to. We've been.
Okay, this one I think. Mm. Okay, this image. Doctor, can you hear me?
Yes, I can hear you. Yeah, go on.
Okay. This is EMR angiography or CTA subtraction. Can we say, Doctor, this?
Yeah, we can say that. Yeah.
Mm.
Mhm.
Okay,
Go
and
on.
here we can see the bifurcations above clearly, and we follows that we have common iliac, then
And
external.
I can see nothing at the moment. I can see nothing at the moment. Can
Okay.
you point? I mean, I can see the image, but I can see no
Okay.
marks or any pointer. Go on.
Okay, I'll mark it. Um, sorry, doctor, this was mistake. Mm, Actually, I'm working with my mobile, so it's a bit. This doctor, at above, it's a bifurcation. Hello.
معك يا Pradeep, معك. But I cannot see any marks that you're pointing to. I'm not so sure that I have to make sure that things are okay. Where's the bifurcation? Obviously, we can all see the bifurcation, but where is it? Yalla, go on.
This okay. Um, this is a external iliac. External, yes. Right
Yeah,
external
this
iliac.
is the iliac. How about the internal iliac? Where's the internal iliac?
This is right internal iliac.
Okay. How about the superficial femoral? Where's the superficial femoral?
And this superficial femoral. This is a left superficial femoral.
Okay. Oh, the popliteal. Can you see the popliteal?
Yes. This is left popliteal, and the other side it's right popliteal.
Okay. You obviously can see the branches of popliteal in the leg.
Yes, it's very
Okay.
clear.
Type. What about the pathology? Go on. What pathology have we got?
Here we can see, I think it's a aneurysm on the left side from the femoral, common femoral.
Maybe common femoral or what? Common femoral or what is
External
more proximal
or external.
or external? What sort of aneurysm is it? What sort of aneurysm is it?
It's
Do you think?
it's a saccular type.
Sacral aneurysm. Angiograms are very easy to interpret. You've already seen different types of angiography. You've already seen the anatomy. You can identify the vessel very easily. It's either a dilated artery or a narrowed one. If it's a narrowed one, you're talking about which artery is narrowed, the degree of narrowing, the length of the narrowing, the artery above it, the artery below it, and the artery around it. That is the collaterals. If you're talking about a dilatation, you're talking about whether the artery is dilated with the opacification of the nearby vein or not. If the artery and the vein are opacified simultaneously, then it's a fistula. If not, then it's an aneurysm. There are no veins that you see in this image, and it's an aneurysm of a second aneurysm of the external common femoral segment. Have we got
Yes.
a runoff? Have we got a runoff, or is this aneurysm causing any problem distally?
No, we have clear distal runoff. I mean, it will not
Yeah,
create problem.
yeah, we're having normal TTs all the way down to the leg. We haven't got any
Yes,
problem. Do you expect the pulses to be palpable? Do you expect
yes, it's we can palpate.
is the aneurysm displacing the vessel? I cannot see the image at the moment, but I think you have noted that the aneurysm was already pushing the vessels to the front or to the side. خلاص يلا, let's go on with another image.
Doctor, on the its knee, it's calcification or what? It's, I mean, patches.
I'm not so sure. It's just an artifact. It's
Okay.
artifactal.
Okay. Okay, this here we can see catheter come clearly. So it's a conventional, sorry, it's a subtraction, digital subtraction angio.
You can see a catheter. Where's the catheter coming from?
It's
Where's the catheter
coming
coming?
from the right right femoral.
So it's the right femoral. The standard retrograde puncture. This is a transfemoral right retrograde transfemoral aortography. The catheter,
Yeah.
already responding to the catheter clearly. You've already seen the catheters coming from above, that is somewhere along the upper extremity, transbrachial, transaxillary, sometimes rarely subclavian. I wouldn't mention subclavian. You've seen direct translumbar orthograms. You've seen direct femoral orthograms. You've seen sort of crossovers when you want to cannulate the right femoral through the left femoral. Go through the left femoral in upward direction. You cross over the aortic saddle area and you're into the right. And you've already seen the standard method, which is the, the retrograde femoral orthography, the one that we're just seeing. This is a DSA clearly. There's a catheter. You can all see the catheter. Point to the catheter once more, yeah, Pradeep, in one of the images where it's very, very clear. Oh, it's very, very clear there.
It's here and also in this portion and beside right to it, and
Okay.
in the middle this one is more clear. This
Okay. Okay. Halas. Okay. You know what is going on with this man or this woman?
here we can see uh, it's left external iliac aneurysm.
You think it's external iliac? You think it's external iliac?
Just a second, doctor. I think common iliac, and then I think
You
it's
think it's common
bifurcation.
iliac? You
Yes,
think it's common iliac? And if you compare the left side with the right side, it's just for the level of the. You can see the external internal iliacs of the right side.
yes.
You can see the internal external iliac on the right side, and this is probably a very distal common iliac aneurysm.
Yes.
Okay, there is the aneurysm
And here
again.
distal runoff. I mean, here this one is the aneurysm. I mean, that not that big, but the smaller one.
Well, I mean, I think it's at least double the size of the iliac, and you never know if can this be bigger? Can this aneurysm be bigger than what we see on the angiogram?
Yes, maybe. Why not? I mean,
Yeah, yeah. What is the explanation? I mean, maybe, but what is the explanation?
because there is a space. I mean, there is a pelvic. It's cavity. There is cavity. I mean, it can also expand.
Yeah, but what? Why can't we see the whole extent of the aneurysm on an angiogram?
Ah, because thrombus. Maybe it's mural thrombosed.
Because it's maybe immunothrombus, so the actual extent of the aneurysm can only be assessed using a CT, but not an angiogram. An angiogram will not show the immunothrombus, but an exit CT will show it. So this is the fallacy of assessing the size of the aneurysm using an angiogram. It may not show completely. Okay, فده a common iliac artery aneurysm. Okay, and this was a digital subtraction angiogram, and it was right transfemoral, a retrograde one. Yalla, go on, go on. Let's review another image. The runoff. How about the runoff? Are you happy with the runoff?
No, here I am not happy.
You're not happy with the runoff? Absolutely. Okay, yalla.
And this one, this is the okay, okay. This here this is the CT's axial cuts of the, in this person we see pelvic, lower abdomen and pelvic areas. These are,
Okay.
and we can see bladder. We can also see the,
No, but see, you have to point to things, yeah, Pradeep, because I mean, how do I know that you see the bladder?
okay,
Water finds the bladder is the bladder. I'm not so sure when the lecture hall it's fine, but this is the bladder,
this
okay.
one is,
And where
and
is the bowel? Where's the bowel? Where's the rectum?
rectum. This one.
Okay. Well, this is the rectum. Okay. What pathology can you see?
Here we can see thrombosed aneurysm.
A thrombosed aneurysm. Is this really a thrombosed aneurysm?
Yes, we can see the whitish. I mean, that is the patent one, and the outside is totally thrombosed.
It's not totally thrombosed. There's flow. There's still flow
I mean,
inside, so
sorry,
it's not a
I mean,
thrombosed aneurysm.
I mean, sorry, I mean to say mural thrombus keda.
Well, it's different. A mural thrombus is not a thrombosed aneurysm. We've emphasized this. A mural thrombus is just a mural thrombus, but the thrombosed aneurysm is when there's no flow whatsoever in the aneurysm. So this is not the case. It's just a mural thrombus while there is flow. Difference. What is the difference, clinically speaking? Clinically
We
speaking, what is the difference?
pulse. I mean, distal pulse we can feel in case of mural thrombus, but in
Uh,
in case of thrombosed, we cannot feel distal pulse.
and how about locally? How about the aneurysm itself?
And locally we can pulse. Sorry, it's expansile.
Yeah,
But in
expansile
thrombose,
pulsations you feel with which type? With which aneurysm?
it's secular. Fusiform.
Or with any aneurysm, unless it's thrombosed. A thrombosed aneurysm will show maybe a transmitted pulse, but all other aneurysms will pulsate and the pulsation will be expansile. أما
Mm,
الثروmbose will not show an pulsations. They may be transmitted. Which
oh,
artery is this one that we're talking about? Which artery? You're talking about aneurysm in which
this one.
artery?
This is it's a right. It's a right common. It's external. It's common iliac. I think right. It's common iliac.
Common iliac. Do you think it's the common iliac?
It's external. Sorry, it's external.
External and extending into where is the bone? Where is the bone? Which it's against which bone?
It's again the femur.
خلاص
It's
يبقى ده extending iliac common femoral. Extending iliac common femoral.
yeah.
Okay.
Okay.
Okay. These are axial CTs. Axial CTs, and you may reconstruct them if you wish. But in this image, these axial cuts were showing this aneurysm of the femoral artery of the right femoral with mural thrombus, extensive mural thrombus, but the aneurysm is still artery is still patent and so on. Okay. And obviously, how did this man present? Do you think? What was the presentation?
As a present as a lump in the right inguinal region, groin region.
It's very clear. Yeah, it's very clear that the man has got a lump on the CTs. The contour of the area is not symmetrical. There's a localized bulge in the region of the right groin. Yes. Original femur. Show me the head of the femur. Show me the head of the femur.
Hello,
Yeah,
doctor.
pretty.
Can you hear me?
Yeah, I can hear you. Yeah.
I cannot hear that question. I mean, my network was a bit weak. Can you repeat the question, please?
Can you point to the head of the femur?
Okay, okay, okay. Um, this
Pin the head of the femur. Yeah, Pradeep.
humor is
The head of the female within the acetabulum.
This I'm in the lower images, in the lower, this one. Can you see the, oh wait, where is in the lower row, Muhammad, in the lower we can see.
خلاص okay. يلا okay, in the lower row صح. Yeah, we can go on, proceed with something different.
Sorry, doctor, actually my network is a bit weak, so that I'm trying to mark it, but network is really weak.
خلاص ما انا بقول خلاص it's not a big issue يعني we can disregard it. يلا we can go on with another image. محمد احنا هيتقفل علينا تاني الساعة 10 الساعة 9 ولا الساعة كام؟ هنخلص بقى متهيألي على 9 ولا يبقى عندنا
It's 8:37.
sorry?
It's 8:37. I mean 8
Yeah, but I
a.m.
mean, what time would you expect the Zoom to end?
I think at 9, 2 hours. I mean, or as you wish, doctor. We are free, so we can continue.
If people wish to continue, I'm ready. ما عنديش مشكلة. يلا go on يا Pradeep, but don't delete the images. Go on.
Okay, this is on my left. It's CT angio.
And I cannot see the same images that you're seeing probably. I can
Okay.
see one كده that is not the one that you want to review. I can see a
This
CT
one is
angiography.
Yes, this one.
طب okay, go on يلا. Go on.
And on
No,
the
but
right,
we want to see the more proximal images. We want to see the more proximal images. It's not this image that we want to see. We want to see the more proximal images that we've just seen a minute ago.
mm,
يلا يا Pradeep, go on with this one. خلاص, this is okay. This is fair enough. يلا يا Pradeep, go on.
this is a digital subtraction angiography. We can
This
see,
is the reflection angiography.
and in the first first row and the first image, we can see catheter coming from above.
You can see a catheter coming from above. Okay.
And here the pathology is so we can see the bifurcation, and then
You want to point to this, please, ya Pradeep, because
okay, I think image has been changed. Okay, thank you, Mohammed. This here, can you see my mark, doctor?
I can't see anything at the moment. I can see I cannot see your mark. You're pointing to, okay, I can see your mark now. Yeah. Okay, go on.
Aorta. After that, it's a bifurcation, aortic bifurcation, common iliac, right and left. And on the left side, it seems external is okay, internal is not okay. Internal iliac.
Follow the right side. Follow the right side. Follow the
Okay.
iliac on the right side.
Okay. On the right side, we have the common iliac, then we have external and internal.
But you have to try to point to these things that Pradeep, because
Actually,
I
doctor,
mean,
my problem is my this in my laptop. I am opening in laptop and also in my mobile. And in laptop, this Zoom app is not updated, so it's not supporting the marker. And from mobile,
no, I mean, how can I know that what you're pointing to or you're talking about is the thing that the correct thing? I mean, how can you know? You are pointing things that Pradeep tried to, please, because
okay, okay.
otherwise we'll be lost. Go on, try to point to
Okay.
things just like you were doing a minute ago.
This is okay now. I think this is
Okay,
this is the external iliac. This
okay.
is internal iliac.
Khalas, go on, go on, go on with the second row.
And this here, let's come to the second. Okay, and this one is the common femoral,
Okay,
and this this is the SFA smalis. This is a profunda, and this is a FA. Doctor, can you see?
I can see you. I can see. Go on. Yeah, I can see.
Hello.
Pradeep, I can hear you and I can see.
Hello.
Alhamdulillah. Yalla, Pradeep, what's going on?
And this is torus. I mean, right? This right. So SFA is becoming torsus.
Is this the SFA really? Do you really think this is the SFA? The SFA is more distal. You can see the SFA in the profunda. But this SFA is not becoming tortuous or anything. What is this? Is this normal or abnormal?
This is abnormal.
Okay, what is abnormal about it?
It's distal. It's dilated. I mean, it's dilated.
Where is it going? Where is it going? Follow it. Where is it going?
It's this one. This one, doctor.
Sorry.
I have marked this one. I mean, it's going. It's running distally. This one.
Yeah, where is it going? It's saying distally. Where is it going?
This thigh areas. Thigh and then
Sorry?
the thigh and then knee.
Yeah, but which side, which knee? Where is it gone? Which side, which knee?
It's right.
Sorry?
Hello.
Pradeep, go on. Go on.
Sorry, doctor. I'm really messed with this image. I don't know why.
You're not missed with this image. Where is it gone? Where is it gone? Just follow it. You're not missed with this image.
It's
Where is
going,
it gone?
okay, it's going to the knee.
Which knee? Which knee is it going
It's
to?
going to right.
Is it coming from the right or is it coming from the left?
It's coming from the right and it's going toward the left side.
Iba,
It's
what
coming
is it?
from the right and
Iba, you can
it's
easily diagnose
fis-
it. What is it? It's coming
fistula.
from the left, right and going to the left. Iba, what is it?
Fistula.
Fistula. The fistula between the right and the left. It's going from the common femoral on the right side. It's going to the left SFA. How come it's a fistula? How come
Mm,
a fistula
I
that
mean
we've created? Uh,
graft.
a graft, how do you call it then? How do you call it?
Bifemoral. Sorry, it's bifemoral graft.
A bifem, you don't call it a bifemoral. You call it what? How do you call it? We mentioned that already.
Uh,
It's Is this anatomical? Is this anatomical?
No, it's by extra-anatomical bypass.
And how do you call it? This is extra-anatomical bypass. How do you call it?
Um,
Between the two
bypass,
arteries,
it's
which arteries is it connecting? Which arteries is it connecting?
It's a femoral, connecting to the femoral, and
How do you call it? How do you call it? If it's connecting this to this, you call the bypass. How do you call it if it's connecting the two femorals? You just name the two arteries that connects your Pradeep. Go on. Go on. How do you name a bypass that connects the femur with the popliteal? How do you name the bypass?
Femoropopliteal bypass.
How about a bypass that connects the two femurs together? How do you call it?
Two femoral, femoral bypass.
It's called the femoral bypass. It's called the femoral bypass. Then you call it the femoral. This is
Yes.
fem bypass. Okay, it's a femoral bypass. Okay, so do you want to wrap up? Do you want to wrap up?
Yes, yes.
Go on.
We saw digital subtraction, and there it shows femoral.
How did we approach the aorta? How did we approach the aorta?
With the catheter.
Yeah, I mean the catheter that is access switch artery.
I think transaxillary. We approached to there with the trans.
Okay, the transaxillary. Okay.
And
what does it show?
It reached to the abdominal distal abdomen, and we saw the bifurcations, and then
yeah, but what did we see? I mean, what abnormality did we see eventually? What did we see?
We see eventually femoropopliteal bypass.
Femoropopliteal?
Yes.
A femoropopliteal bypass? Did we see a femoropopliteal bypass? We saw a femoral bypass.
Here in last image, it was down. I mean, it was going to the down.
A femoropopliteal bypass means that it's the same side, yeah, Pradeep. You've come from the right to the left side. You've crossed it over. It's a crossover.
Yes.
This is a bypass from the right side to the left side.
Yes,
it's a femoral bypass. It's a femoral bypass. If you call it a femopopliteal bypass, then you mean the ipsilateral. It's a femoral bypass. You call it a femoral. It's an extra-anatomical femoral bypass. Okay. يلا عاوزين نجيب فيلم تاني بس غير الفيلم ده. لا ولا ده. Let's forget about these images let's forget about these images also.
Okay.
كمان معلش لا حاجه بس ريتد للي احنا كنا بنقوله عشان تبقى كلير بس. يلا لا كمان يا محمد معلش. كانت جت قبل كده. يلا كمان. لا متهيألي كانت قبل كده خالص يا محمد. كانت في
واحنا كده يا دكتور رجعنا خالص، يعني احنا في الاول.
ما احنا كانت في الحته اللي انت جبتها في الوسط كده كانت جت، وبعد كده واحنا بنشوف الفام الاخيره دي كانت قريبة لها يا محمد، معلش نلف تاني كده.
تمام اوكي.
معلش. كمان يلا. بس خلاص خلاص يا محمد كده. لا هي دي يا محمد، هي دي اللي فاتت.
تمام
على
دي.
مهلك على مهلك. لا ممكن دي، او كانت في واحده فاتت اظرف منها. اوكي خلاص خلاص، ايوه 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 هي دي، ايوه هي دي. يلا براديب جو اون.
This is the CTA,
اوكي
and we can see clearly axillo-bifemoral bypass.
يبقى اهو axillofemoral، يبقى اهو fem the fem part of the axillofemoral. Point to it.
Okay.
Point to it.
تمام. This.
Okay, it goes all the way up to the axillary. You can identify it as a graft. Can you see the crimplings of the graft and the fem? In the fem part of it, the fem you pointed to it also. Why did they perform the axillofemoral? يبقى a clear axillofemoral, a clear axillofemoral.
Yes.
Okay,
Because aortic bifurcation is totally blocked.
only the aortic bifurcation. Where is the block going up to?
Common iliac. This area.
This area, I mean, identify this area. Where is this in the aorta? Which part of the aorta? It's blocked all the way up to the.
Distal to
Blocked all the way up
the renal artery.
to the renal arteries. And which artery is coming just above the renals and going down, and it's still patent?
It's SMA.
The SMA. So this is what we call a high aortic block. It's a high aortic block. It's a block all the way up to the renals. But this has been treated using an axillobifem, like Pradeep was telling us, an axillobifem. The other image that Pradeep was finding difficulty in assessing was a fem. But this is an axillobifem. Okay, يلا go on. يلا يا محمد ورينا ايه تاني، عندنا ايه تاني. ايوه يلا Pradeep go on. How about this one?
This is reconstructed CT.
Reconstructed CT.
And here we can see femoral bypass.
Point to it. Point to it. You can just femoral bypass. Go on with the other image. This is maybe an oblique one. Go on with the image to your right hand side. بلاش oblique images يا Pradeep. There is one in the middle where it is absolutely اهي. You can all see the fem, which is the donors.
Muhammad, the previous one, please.
Yes. Where is the donor side and where is the donor side and the recipient side?
Donor is the left one and recipient is the right one, because
what is the original pathology? What is the original pathology?
Because of the blockage of the right common iliac, total common iliac plus external iliac.
Okay, so an anatomical bypass, axillofemoral, femoral, reconstructed CT. Let's look at the axial cuts and tell me what's going on. Look at the axial cuts, the ones just lie at the lower row.
Okay. Here.
Yalla, point to the fem. Where's the fem?
Okay. This one.
This is the fem. What's happening? What's happening with this fem?
Here it's a bit. I think at the distal one on the left there is a dilatation.
Yeah, what do you mean by dilatation? The arterial tree dilatation is called. It's got a name. It's got a name.
Aneurysm.
An aneurysm. طب خلاص, it's got a name. You don't call it a dilatation. You just call it an aneurysm. Well, because it's in an operative site, you call it an anastomotic aneurysm. This is where they've anastomosed the graft to the artery and it's leaked. And it's called an anastomotic aneurysm. If an aneurysm occurs at the site of an anastomosis, you call it an anastomotic aneurysm. Right? It's very clear. And it's clear on the axial cuts, but it's clearer as we see on the axial cuts home.
So I mean, this one is a femoral bypass, and we have aneurysm at the left side of the graft. Bypass end.
Yeah, you call it an anastomotic aneurysm. You call it an aneurysm develops at the site of an anastomosis. It's called an anastomotic aneurysm.
Okay.
Okay. So, yalla, go on. Go on. We'll review another image. عندكم حاجة يا جماعة ولا هنكمل قد إيه دلوقتي؟
مش عارف يا دكتور، يعني احنا يعني على حسب حضرتك يعني عايز ايه احنا ما.
لا يعني ممكن نكمل كمان لغاية الزوم ما تخلص لو انتوا فاضيين. مش عارف يا محمد انتوا عندكم حاجة ولا ما عندكوش؟ زي ما انتوا عاوزين. أنا موجود أنا ما عنديش مشكلة. وهنتقابل السبت ولا مش هنتقابل؟ زي ما انتوا عاوزين برضو، أي حاجة انتوا عاوزينها. أي
دكتور، هو
حاجة.
حضرتك عرفت ان الاجازه يوم الاثنين مش الخميس، صح؟
أنا عرفت
تمام. يعني احنا هننزل الثلاث ولا مش هننزل الثلاث؟
لا هننزل الثلاث. ليه مش هننزل الثلاث؟
تمام. لا انا بسأل عادي.
لا ما احنا ممكن. انا ما بقتش عارف حاجه خالص دلوقتي. احنا عندنا اجازه 5 ايام، دي حاجه ما حصلتش يعني. فدلوقتي نتلاقي ننزل 3 و4 و5، مش كده ولا ايه؟
تمام يا فندم.
لا مش تمام زي ما انتوا عاوزين يا حازم. انا مش عارف انت حازم مش كده؟
يا فندم، انا حازم. ما هو كده
طيب
تمام،
يعني
كده مظبوط. يعني 3 و4 و5 احنا قاعدين في البيت سبت حد اتنين.
مش احنا كنا ناخد اجازه السبت بدل الثلاث خلاص
ده
ولا ايه؟
المفروض
مش كده ولا؟
بس يعني من الاسبوع اللي بعده بقى، لما الايام تتظبط يعني.
من الاسبوع اللي بعده. طيب
ما هو احنا
خلاص.
السبت، ما زي ما حضرتك قلت، السبت الجاي اللي هو بعد بكره ده اونلاين.
اوكي خلاص. السبت ده اونلاين برضه. هنكمل الصور ونشوف بقى نتقابل الثلاث. لو الثلاث عاوزين ناخد اجازه يبقى نتقابل الاربع، مفيش مشكله.
اوكي يا دكتور، تمام.
This image, doctor.
Yalla Pradeep, what's going on here?
Okay, this is a CTA that was showing axillobifural bypass. No, it's unifemoral. It's not bifemoral, I think.
It's unifemoral. So
Yes.
this is the upper part of the fem of the axillofem. Where it
Yes.
shows like Pradeep was telling us a unifem, an axillounifem.
This one, it's coming to the femoral. This I have marked it. Can you see the mark?
Okay, yeah, I can see the mark. Yeah, yalla, go on.
And here the problem is this common aortic bifurcation. Common iliac is totally blocked. I can mark it. This area. This area, it's aortic common iliac is blocked, and the vessel that's coming down, it's yes, okay, renal artery is above, so I think it's inferior mesenteric.
Yeah, it's inferior mesenteric.
Hello?
Yeah. Pradeep, I'm following you. I'm following.
Yes.
Yalla, Pradeep, go on. Yalla, Muhammad, let's proceed with the next image.
أكمل يا دكتور ولا نشتغل دي؟
لا دي خلاص، دي هي هنسيبها.
This. Hello?
Yalla, Pradeep, go on. Let's just concentrate on this image. Yalla, Pradeep.
Okay. This one is yes, we can see the I will show the this is digital subtraction, and we can see the catheter in the lower row from below.
The catheter from below.
Yes,
Look at the upper rows here, Pradeep. Look at the upper rows. Look at the upper rows. Look at the upper row.
Yes, there is also yes from above.
So there isn't the catheter from below. Where's the catheter that you assumed it coming from below?
Doctor, I have marked it. You can see that circle. I mean, there is also from below.
There's no catheters from below.
This one,
The
I
catheter
mean,
is coming from. This is not a catheter. This is an artery. It's not a catheter.
oh, okay.
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 دكتور ممكن يعني يعمل مارك على الكاثيتر اللي من فوق لو مش شايف.
I'll mark it.
Where's the catheter is coming from above?
It's exactly at the. It's. I mean, we can see the U shape. Hello.
The catheter. Yalla, point to the catheter. It's very, very clear. Yalla, Pradeep, point to it. You cannot just put a rectangle around it. Just point to it. It's there.
It's exactly on the left of it. Actually, in mobile, I cannot point it exactly. It's not zoomed at. So.
Okay, خلاص يا Pradeep. Go on. So what's going on with this man?
And here.
حازم شفتها؟ حازم شفت القسطرة؟
يا فندم.
Okay. يلا Pradeep, go on.
And here we see it's right on the second row. I can see, I mean, left common iliac is this one. Left common iliac. What happened? Hello.
Pradeep, go on.
I have in second row. I have marked the left common iliac, but on
You're
the right
choosing
side.
a very bad image, Pradeep. Choose a properly subtracted one. You've chosen yeah. Go on to the images to your right hand side. Go on. Where's the left common iliac?
Okay. This one is the left iliac. Is common iliac.
Have you seen common iliacs before, Pradeep? Does this look like common iliac, for God's sake? You've seen common iliacs before. Does this look like common iliac? Where's the common iliacs? Point to the common iliac. Where is the right common iliac?
Just a second.
Pradeep, can you hear me or can you not hear me?
Yes, I can hear you. I'm trying to annotate it. I think it's blocked. Right, you mean right common iliac?
Well, point to it. I mean, you think it's blocked. We're a group that we're trying to show things to one another. Where's the right common iliac? If you can do that at all, show it. If you cannot, then you cannot.
Yes,
Where's the right common iliac?
right common iliac. It's blocked. I think it's like this one.
It's not blocked. It's not blocked. It's there.
Sorry,
Oh,
yes,
oh, there's the right common iliac. So
yes.
there is the right common iliac. Which artery is blocked distal to it?
It's external iliac.
The external iliac is blocked, but the common iliac is there. Can you
Yes.
see the internal iliac? Can you see the internal iliac?
Yes, this one is the external iliac.
The internal iliac, the internal, not the external, the internal iliac. The external is blocked.
Yes,
In the
yes.
internal iliac.
This one in another image I will show it. This one is internal
You
iliac.
want to erase? Do you want to erase? اهو بالضبط. يبقى the right external
Internal.
iliac is blocked.
Yes.
Okay. طيب يبقى and how about the left? Where is the left external iliac? Where is the left common iliac?
This is the left common iliac. This one.
This one. So we've got something, a third thing. So what you were pointing to as the common iliac in the first place is not actually the common iliac. What is it? Review this image and the image below it. You know, what do you think it could be?
It's internal iliac. Or what?
Do you really think this is the internal iliac, Pradeep, coming out off from the aorta?
No.
Follow the aorta, follow the aorta, follow the aorta.
Okay.
Start with the aorta from above. Follow the aorta from above.
This is the aorta.
This is the aorta, and it's dividing into two common iliacs. Yes,
Yes.
but what is arising from it? What is arising from it? There's something arising from it.
This one, I think this is a bypass.
This is a bypass. This is a bypass. Yeah. This is a bypass, and where is all? It's going all the way down to the
Right side, right femoral.
only the right femoral. Only the right femoral. Well, is it
Plus,
bifurcating?
yes, it's bifurcating. It's to the left.
So what? So what is it?
It's auto bifemoral bypass.
This is the aorto bifemoral bypass.
Mm,
Okay, so this is aorto bifemoral bypass.
yes.
So you start with the anatomy. You start with the anatomy, and you've already identified the vessels, different segments. You should be able to identify this as a normal vessel or as a bypass. Bypasses have not got the same course, and they haven't got any branches whatsoever, obviously. Yalla, so wrap up, yalla.
Okay.
You can see, Hazim, can you see the catheter quite clearly? And it's coming all the way from the axillary.
اه يا فندم مظبوط.
Yalla, Pradeep, a wrap up, a wrap up.
So it's a digital subtraction angiography showing aortic and bifurcation block. So
How did we catheterize the aorta? How did we catheterize the aorta? How did we access the aorta?
transaxillary
It's
side.
a transaxillary, probably a transaxillary. It's definitely from above, so it may be transaxillary, maybe transbrachial. So this is a transaxillary DSA, digital subtraction angiogram. And what does it show?
Because it shows the catheter above.
What does it show? What does it show?
It shows block. I mean the aortic bifurcation block and graft in the aortobifemoral graft.
Aorto, is it an aorto bifurcation block? Is the aortic bifurcation blocked really? What is blocked?
No, it's not aortic bifurcation block.
So why are you saying aortic bifurcation block if it's not? What is blocked? You've reviewed the artery. Which part is blocked?
This is block external right external iliac
The
artery
right
is
external
blocked.
iliac. The right external iliac, and probably the left as well. I haven't got good evidence for that, but it's there. Okay, it's not the aortic bifurcation. It's an iliac block. It's an iliac block where you can see the aorto bifemoral all the way down.
External iliac.
Point towards the anastomotic sites of the aorta, the graft to the femorals. Where are the anastomotic sites of the graft to the femorals?
this anastomotic. These two are the
There,
anastomotic sign.
yes, yes. So this is a transaxillary DSA showing an aortoiliac disease, the level of extended iliacs, and an aortobifemoral bypass. Is the flow distal to the bypass okay?
Yes, it's okay.
Yes, it's okay. خلاص يبقى let's proceed. يلا يبقى a beautiful image يبقى شفتم axillo by fem aorto fem كله to consolidate what we've been talking about. يلا هنشوف what comes next. What is next?
Image. Okay. Here, this is a plain film showing a stent all along the superficial femoral artery in the right side.
Is it just one stent? Is it just one stent? And is it only the
No,
superficial femoral?
it there it's let me mark it. Uh, this one is first, okay, and then we have this long sec. I think this second and the lower popliteal P1 portion. This one is it, doctor?
Sorry?
I mean, I have marked. I mean, it's three parts together. One in a external iliac, and then here so ASFA,
Iliac,
and
is there
then
a stent in
I
the
think
external iliac?
popliteal.
Wait, hold on for a minute. Is there a stent in the external iliac? Does it extend beyond the head
Sorry,
of the
doctor.
femur? Pradeep, what's going on?
Hello.
Pradeep, can you hear
So
me?
yes, I now I can hear you. So here it's a stent has been placed.
Yeah, where? Whereabouts? Placed where?
Doctors, I'm really sorry, but I didn't hear your voice because of my network is very weak.
Where, where was it placed? Where was the stent placed?
It's above in external iliac. It's femoral.
Does it femoral? It's not extend iliac. It does not extend beyond the head of the femur. So it's femoral. It's
Yes, yes,
femoral.
yes.
If
It's
it overlies the femur, it's femoral. Very simple. And then where is its distal? How about distally? Where does it extend distally?
part of the
Pinya Pradeep.
P2 also.
Without the P's, people may not know it. It extends into popliteal. So it extends into popliteal clearly.
Yes, it's
Why did you say that there are more? Well, why did you say there is more than one stent? Why do you think there's more than one stent?
because of the barbs.
The barbs are there. The barbs are there. You can identify the barbs. Point to the barbs. Point to the barbs.
Okay. Uh, this one is the
هم دول الباربs بالظبط. You can easily identify a stent. You can easily identify a filter. You can easily identify a venogram, an angiogram. You can easily identify a bypass, I hope. Different levels of block. Aneurysms, aortic aneurysms elsewhere. Yalla, let's continue. Let's view another image. Yalla, Pradeep, what's going on here?
Okay. Here is a plain film, and it shows.
You have to say where. Where is the plain film, ya Pradeep? Where is the plain film? You start describing things by the site. You cannot
Yes.
just say a plain film of the head, of the neck, of the chest. I don't know what.
It's a
Where
plain,
is it?
plain film of the pelvis.
The pelvis. Pelvis. Yes, the plain film. Is this a young man or an older man? Is this man young or old?
It's a young
They're young. Why did you say they're young?
because of its epiphyseal plate. It's still, I mean, not completely.
Yeah, but it does not show fusion of the epiphyseal cartilages, so it's still this, and you can see which cartilage you're talking about.
Okay, I will mark it. This
Yeah,
one.
the upper head of the femur, but can you see another epiphyseal cartilage that is not fused?
Yes. This one, this on the both side. It's a acetabular. It's
The acetabular, yes. Yes, and what did this young man sustain? What
I
did they
think
sustain?
shotguns, multiple shotguns.
A shotgun, yes. How did he manage his bleeding? He was bleeding badly. How did you manage his bleeding?
Oh, there is a wire.
A wire? You don't call it a wire. A wire is a guide wire. It's not a wire. It's a coil.
A coil, sorry, malice. It's a coil.
Coil. Coil. There is the coil. So this man's internal iliac has been coiled in order to stop the bleeding.
Okay.
Okay? A coil. You can see these coils also in the head. What do these coils do in the head?
In the head.
Yeah, if you identify a coil in the head, so what was in the story?
In head, for suturing masalan, or maybe
For what? Sorry?
for, I mean, to fixing two bonds together.
No, a coil, a coil, a coil,
Shunt.
Okay.
a coil, a shunt, a coil inside the head. A shunt is a shunt. Maybe you have seen a shunt before, but a coil. What do you coil inside the head? We mentioned that before, and you know it.
Maybe
Eh?
aneurysm.
An
For
aneurysm. An aneurysm. You coil an aneurysm. An aneurysm of the circular veins that causes subarachnoid hemorrhage is coiled. It's
Okay.
not. Okay, go on. Yalla, let's proceed.
Next image.
This was the plain film of the pelvis in a young man who has sustained a shotgun, and he was bleeding from his pelvis, and he had his internal iliac artery coiled instead of being explored and losing a lot of blood.
Okay. Mohammed, next image, please. Okay.
دكتور معلش، هو الميتنج هيخلص كمان شوية، احنا هنكمل تاني ولا هنقفل خلاص بعده؟
بالتالي هنقفل بقى. لو هيخلص كمان 10 دقايق يعني، ولا دلوقتي على طول؟
بالتالي كمان 5 دقايق أو حاجة.
طب خلاص، بالتالي بقى نخلص عند النقطة دي، وهنتقابل السبت. اتفقنا ولا هناخد اجازة الثلاث؟ ولا هنعمل ايه؟
احنا ممكن ننزل التلاتة على طول وناخد السبت عادي اجازة، لو حضرتك حابب،
خلاص.
ان احنا كده هناخد يوم الخميس راديولوجي يعني.
خلاص، يبقى احنا هننزل الثلاث ده كأننا ابتدينا الاجازة السبت، ونأجز السبت بكرة او بعد بكرة يعني، وننزل الثلاث ان شاء الله.
تمام خلاص، اوكي يا دكتور، ان شاء الله.
يعني هتبقى دي الخطة بتاعتنا، ننزل الثلاث ان شاء الله. 3 4 خميس ده لسه هيبقى العيد الاسبوع اللي بعده، مش كده ان شاء الله؟
باذن الله باذن الله.
خلاص. شكرا يا محمد. Pradeep, thank you very much.
العفو يا دكتور،
Thank you
شكرا.
so much, sir. Thank you, Mohammed.
Pradeep,
Thank you so much.
Thank you Pradeep. Thank you يا
You're
محمد. شكرا يا جماعه على كنتوا موجودين النهارده في يوم الاجازه، وان شاء الله اشوفكم بقى يوم الثلاث. كل سنه وانتم طيبين.
حضرتك طيب يا دكتور، مع السلامه.
كمان دكتور.
دكتور حضرتك طيب.
كل سنة وانتم طيبين، كل سنة وانتم طيب يا زين. كورولوس كل سنة وانت طيب.
سلام.
كورولوس شكرا يا محمد.
كل سنة
العفو
وحضرتك
يا
طيب.
دكتور، شكرا لحضرتك يا دكتور. حاضر، كل سنة.
دكتور